so we chose a disease that is more mature than any other cancer in terms of knowledge about genetic rearrangement and mutation. And we chose it for the reason, even though the patients are few, the implications of receiving a diagnosis of leukemia is huge, and the knowledge about the genetics is great. And so we were looking at, forget about the sort of the greater economic impact, we were looking to implement a test that would be cost equivalent, just the test. So if you look at what's currently done, standard cytogenetics plus the requirement to do 4 mutations, those are NCCN guidelines in order to stratify patients to a risk status, that with current testing method is approximately $1,500. And so with the decline in the cost of sequencing, we were predicting that by the end of this cycle, we would be doing the test for that or even less than that. So based on the fact that we started with a disease where the knowledge is already great, we're hoping to at least achieve cost equivalence. So that's one thing. But the other, I think, point is, it goes back to one of your opening comments about the business of health must include research. So you can't separate the two. And so if you look at the first, what I think is the first genome-wide test, which was standard karyotyping, we knew nothing. In the 60s, first translocations were described. And over the following decades, we learned a lot, which helped us stratify patients, which helped us improve outcomes, and or at least learn how to deal with patients with different types of diseases, such that now cancer is no longer cancer, but multiple different diseases. So by implementing tests from our viewpoint, where the cost differential is, we think, nullified, and we get the value added of learning as we go along how to sub-stratify, how to manage patients better, that seems to be a problem.
So it's a good question, but one thing that all of us alluded to this morning but didn't really focus on is that beyond all the steps, the life cycle of developing, in our case, an omic biosignature that corresponds to either predicting or the actual patient phenotype and outcome, or the need for intervention or change in therapeutics, is that clinical thought leaders are looking for solutions. And so it isn't like you said, so I would push you back, which it isn't like you said, these are tests looking for a place to reside. These are driven, as I said, entirely by clinical need and by clinical acumen of cold-faced clinicians. And so there's a desperate need in some instances, in the instance of monitoring for the potential occurrence or the actual occurrence of rejection. There's a major need that's been there for, I would say, 2.5 decades. If you use the example of heart transplantation, where if you go in and you look at the literature and people seeking a better way to diagnose, even not predict, but just diagnose allograft rejection in the heart, and Paul can speak to the kidney. People have really been seeking a solution in the blood or through electrical changes or other indicators to replace the invasive, costly procedures that are currently still used. And so if you take, so there's that. And then if you take, in the case of transplantation, the FDA approved in 2008, approved AlloMap as a test under XDX, the expression diagnostics of the Bay Area, without any clinical trial. It was approved because of this need for a better way of diagnosing or in this case with their test, which is a rather poor test. And I won't go into all the reasons why it opened the door for subsequent better tests, but it has only negative predictive value, and it has negative predictive value after most of the acute rejection has occurred. And yet it went through FDA approval. It has about a 25% market penetration in the United States, minimal in Canada and Europe. But it didn't actually undergo what you call an evaluative clinical trial. And I'm not saying that we necessarily shouldn't do that. And in our BIT 3 program that we hope will be soon fully funded, we will do a local observation side by side with the biopsies or with the biopsies of other clinical indicators side by side with the signature to look at patient outcomes in the 2-year period. And that will not be a trial, but it will be the forerunner to bringing it into clinical practice. And I think if you can show that you have both positive and negative predictive value and reasonably high sensitivity and specificity, realizing as you do that if you go in the clinical laboratory, that most clinical tests that are used in all of the clinical laboratories around the world right now have sensitivity and specificity of around an AUC of about 0.6, 0.65. And so anything, when we show you the receiver-operator characteristics curves today, these are stunningly higher than most of the tests that people or physicians in this room use every day to guide management of their patients. So if you can take a test that's not invasive, it's closer to home, you can get a blood sample drawn in Kelowna and not have to come and have angiography in Vancouver or a biopsy of your heart. It's timely, you have turnaround that afternoon, and it costs half as much or less, and the patient feels better because they're not being invaded. It's pretty easy to make the case that you could go ahead with this test in a focused area of adoption, early adopters, without a real full-blown clinical trial. That's sort of my thoughts.
Okay, Bruce. So, just very quickly, I think that you're right that all of these things need to be evaluated prospectively to understand their utility. And but in some ways, I feel like our work is actually driving clinical trial design because it wasn't there before. That because now we can look at these things not just as side effects on the way to effect, but we can look at them as independent outcomes in their own right. The question is, boy, if we lowered the dose, what could we do to avoid that effect? And how does that affect survival, positive and negative? And this becomes really important. And I'll just end with a quick story. About 6 months ago, I got a call from a local physician who said, I'd like genetic testing for hearing loss for my daughter, who's just been diagnosed with neuroblastoma. So I said, tell me a little bit about her. 18 months of age, stage 4 neuroblastoma. That means less than 20% chance of survival. Okay? So when he told me that, I said, cisplatin is the drug of choice. So the genetic basis of hearing loss would be interesting, but your child needs cisplatin. That's the best shot she has. And I don't want to suggest for a moment that survival is less important than hearing. And he began to cry, actually, on the phone and said, you don't understand what I'm asking you. I'm a physician. I know what her chance of survival is, and that chances are within the next 6 months she'll be inherited. So my question is, do I want to make her deaf? Will I make her deaf? In the last 6 months of her life, so he said she's 18 months of age, she speaks 2 languages in full sentences. Hearing is everything. And his wife is a professional musician. So high frequencies are what you lose first. Most of us don't even know we lose our high frequency hearing. Okay? So it's this is a very compelling case. So if the patient wants the information to, again, reduce the uncertainty associated with drug harm. Pretty good example, I think, of how testing can help that family make a decision. If they don't have the hearing loss variants, then the therapy we're about to commence, I don't feel bad that I'm making a decision does have the hearing loss variance, not using it is a big question my wife and I have to wrestle with. Anyway, long story short, we tested and no hearing loss variance, so therapy proceeded, and that's the interesting.
Thanks very much. Questions from the audience? So, just before, like a wrap-up, how much time do we have? 5 minutes, yeah, so maybe a wrap-up question. Because these tests are like the horse before the cart sort of thing, of necessity, and I think that's of necessity. You all spoke about economic modeling, and I have this debate with health economists repeatedly. How do you account for the quality of evidence going into the model? Now, if you speak to health economists, they'll tell you, oh, it's easy. We do sensitivity testing, we run 10,000 permutations, and we deal with uncertainty through the 10,000 permutations going into the model. They've actually admitted now, and after kind of a lot of interesting discussions, that when there is poor quality evidence going into the model out of systematic review and aligning it to grade or whatever, they prepare now to say that the economic model shows cost effectiveness is X, but the quality of evidence is low, which makes you pay less attention to the economic analysis. And I gave the example of this really sophisticated economic model that Theta did for us on Oncotype DX. Beautiful model, unbelievable. But it says quality of evidence low. So because you're coming in at this, before a lot of real clinical testing and trials have taken place, how do you build the economic model based on the fact that you either haven't got evidence or you've got low quality evidence?